contributing this morning, I said I've been out of the ICU for some years. In fact, I remember the day I completed CCN, and after the internship, I didn't feel like going back to the hospital I came from, but I had to go. And since the day I went, I have never regretted, because I have contributed to saving so many lives. So many patients that would have ended up at the ICU, the resource-constrained ICUs. Sometimes we even refer patients to hospitals and there are no beds at the ICUs. That's about 3-4 weeks ago, we referred a case from my hospital to one of the regional hospitals. And in fact, I saw that this patient was an ICU patient, and I knew with some level of intervention, this patient would have survived. When they got to the facility, no bed. For 30 good minutes, we lost the patient in the ambulance. And when you trace the history of this patient, this death would have been prevented. Why? Because the whole thing started from a CHIP compound and ended up in a hospital. So this woman finally came back to the CHIP compound and was not finding solution. So they ended up in a prayer ground. Until the whole thing became serious, then she came back to the hospital. So whose cause? We want them to come to us. And when you look at the ANC card, he was a regular attendant at the ANC. So where is the gap? We want them to come to us. They come to us, we are not able to take care of them. They go back to the community and then back to us. So how can we as CCNs leverage? How can we be made visible? Sometimes I see some situations and I feel like doing something, but I'm alone. What can I do? The people surrounding you don't have the third eye to see what you are seeing. And when you talk, it's like you are talking too much. It's like you are the only person seeing what you are seeing. You see, it's very painful and sad. So we need you through networking. Even if not at post, we can network, build capacity so that we can bring change. Now we want to achieve universal health coverage by 2030. I don't know, from where I sit and what I see, I don't know if we can really achieve what we want to achieve. SDG Goal 3, can we? Now we've brought in the network of practice. I don't know how they are going about it. Are CCNs involved? Or is it going to end at the health center CHIP compound or the preventive zone? Then we'll write nice reports that we are practicing the network of practice. How are CCNs going to be integrated into this system? And not only CCN, but the specialists or whatever you call them, specialized nurses, CCNs, PONs, ophthalmic, ENT. Can we come together and make ourselves visible? Because I think with our intervention, something can be done. So I'm going to do this presentation. The presentation is not to report anyone, to undermine anyone, or to say that somebody is not good or whatever. We just want to see some of the things that are happening and how we can help, we can support our CCNs or specialized nurses. So we have the outline and introduction. Compromised patient safety at the district and sub-district levels is having serious consequences on individuals and communities. Serious consequences. You will see it in the pictures that I'll be presenting. Some common things that contribute to the compromised patient safety at these levels are shown. So we'll see it. So the objective, as I said, is not to undermine anyone, but rather to raise awareness about patient safety concerns in the district and sub-district levels, inspire policy changes and quality improvement strategies, and then foster collaboration among stakeholders. We have so many things on paper, so many policies on paper. How are we implementing them? We write nice reports at the end of the year. What is happening on the ground? The infection prevention control concerns at the sub-district and the district level. I was working in the Volta region, the Volta Regional Hospital, the then Volta Regional Hospital. Then my husband was transferred to a place, so I had to move. I was a PNO by then. I was a nurse manager in another facility before coming. So I had to move to a health center. So my first day at the health center, what I saw, I wondered if those people were also nurses and if that facility was also part of the healthcare delivery system. I couldn't withstand it. I started intervening and the challenges started coming. They couldn't understand why I was doing what I was doing. So the yellow container you see there is a dustbin. That's in a typical health center. And you can see something inside. That's a gauze that is soaked with blood and some other infectious waste. So the next question is, where are they going to dump this waste? So that is it. That's the place. And this place is just close to the facility. And this one, we have even handled it small. So the rubbish was almost entering the facility. Pads and other things were just there, scattered. The place was so bushy. And as you can see, that's a building. People were living there. In the corner there was a placenta pit that was smelling with flies and other things settling there. And on this rubbish dump, you see goats, cows, fowls, and other stray animals patronizing that place. And those cows and goats will surely end up in the Wache Celestial. So I intervened, and finally, at least there was a change. So you can see some of the IPC concerns. You can see the needle. In fact, these are some of the finest pictures that I've brought out. The finest ones that I've brought out. Some of the things happening. There's no third eye there to see. There's no third eye, so you can see. So in that drum there, that is the addressing drum. So as you can see, that cotton wool, is it autoclaved? Can it be autoclaved? And it's opened. So this is what we use to dress our wounds, both the surgical and whatever, any wound that comes in. The RTAs, when they come, that is what you see better ones. So one day I decided to enter where they do the dressing. And this is what I saw. Can you see that thing? It's a trolley that we use to, it's a stretcher. So I may say that is the dressing trolley with the items. Both the top shelf and the down shelf are on the top. And the trolley itself is here with the drums. You can see the register there, some cotton wool and other things. And this is where we do our dressing. It was a very small room. I was shocked. And one day, I was there when they brought this child, about 3-year-old child, with deep lacerations. So I followed up to see how they were going to do the suturing and other things. And that's what you can see. They did the suturing all right. So you can just reflect on the environment where they did the suturing. Then you see the wound after some days. So they finished And after 3 days or 4 days, they brought this child. I was somewhere and I heard a stench, so I went out. In fact, I couldn't withstand it. So from that day, I took up the dressing. So I decided to do the dressing. So I went there. Sometimes you cannot blame them so much. Environment, the items to do the dressing. But if there was a third eye there could be some innovations, intervention, other things to support. So even the dressing solutions and other, nothing was there. So I asked whether they had autoclave. They said they had. So I followed up, saw it was functioning. So we started using it. So I decided to start use the wound dressing with Savlon and normal saline. So I started from this child. And after 1 week, that was the state of the wound. So initially when I started, the dressing room and what happens, collection of money and all those things. They thought I had blocked them. So there were so many issues, so many insults and other things, but I didn't mind. So I continued. Then some of the nurses started understanding what I was doing, and they were also. So I took up the dressing for about 3 months. So one day I went to where they do the decontamination, and that was the decontamination solution. So where is the third eye? So this is another area. I like doing monitoring and supervision and then auditing. So in fact, where I've worked so far, they are all challenging places. Whenever, probably because I have the third eye. Yes, so as soon as I get there, I decide to institute the processes for auditing, monitoring, so that we can improve the situation. So one day I entered one of the units, their decontamination room, during an audit. And this is what I saw. If the items are not there, logistics are not there, they are not there, gumbook, we don't have. But this, they bought it. I'm sure they bought it for peer review. And after the peer review, that was it. So then I brought it out. So the next time we went for the audit, this is what we saw. So it means something can be done. PCNs, you have to move outside the ICU. So in another facility, I went in. If you are IPC inclined, once you see the yellow, what does it mean? Yes. So then my first time I got there, this is an administration block behind. I saw this and I said, what is happening? So I started the monitoring again. Then we decided, we bench all these things. I organized weekly communal labor. In fact, management supported me, the administrator, they all supported me with the orderlies. And I had a very good environmental officer. They had an environmental officer who was very hardworking, but he was not being used. So as soon as I got there, I got hold of him. So he supported me so much. So we bench all this thing. Now the place, somebody is farming there. Very beautiful, you see. And that is another placenta pit. If I can take the whole facility. So other IPC concerns. So another time, utility gloves. I'm sure it was purchased for a peer review. After that, it's left there to decompose. Maybe the next peer review, then we'll provide the things, and that ends it. And that's another decontamination solution. And those are instruments left in the solution rusting. Another time, I decided to just visit the theater. I will not blame them. I think it's not there. So the person there has also tried. Even the space for the theater, when you enter there, the first time I entered there, I was like, wow. I couldn't, there's nothing. It's an infrastructure issue. You can't do anything. Logistics. So this is the theater sink. The amount of money that moves out from that place. Maybe health insurance is not paying, whatever. So that is the sink. And do I say that is a boiler or whatever? I was like, hey, so what is happening here? So at least we don't have anything, so what can we do? We can clean. So the next time I went, I think that after the cleaning, this is what I saw. And that is arrangements of units in the theater. Items. These are the finest pictures. These are some of the finest. Because we can't wash our dirty linen outside. But I just want us to look at it and see how we can help the system. So injection safety practices. This is one of the best pictures I've brought. Sometimes when I see some, I just cannot withstand. I have to quickly take my glove and change it. Some of these patients might not even have the money to come to the ICU, so we lose them. And in Ghana, we cherish maternal mortality, neonatal mortality. If a man dies, nobody follows up. You and I, if something happens to us now, nobody will ask for audits. If it's maternal death, if it's neonatal death, that one, they will call you to audit. So, can we research? I'm ready to offer my hospital. Can we do something? My hospital, mortalities, can we probe, come out with something and implement? Now that they said network of practice, can we identify the gaps and see how we can support in this network of practice? Otherwise, this network of practice will talk, and nothing will happen. So this one, very recent. This man was brought to the hospital. In the corner there, that is the leg. Will I say cellulitis? He was brought to very septic. When you see the man was almost dying. What happened? A supposed nurse was managing him at home. Now we have, what is happening is that we have chemical shops or pharmacy shops who have almost turned into clinics and hospitals. Almost everywhere we have a pharmacy shop, we have a clinic. What is happening there? And they manage cases that end up in the hospital. This is one of the finest, as I'll keep on saying it. Some of the sins are very bad. So the man came. So quickly we sent him to the theater, and this is the outcome. This person has taken money, treating the patient at home, and not even identified that the leg is almost going. So dressing. What are you dressing? If I call the person, up till now I said you should come and see me. She has not yet come. And she confessed that she's not a nurse, but she has ever worked in a hospital. I wanted her to come. So you see what is happening. And there are some that nurses and midwives are also involved. So we took it up. In fact, my medical soup is so passionate about some of these things. So, in my facility, I'm now in one of the newly constructed hospitals. So, when we went there, fortunately, I have one PON. So we took up capacity building. We realized In fact, things were not good at all. So we started training, especially on IPC, before we even started operation. And we started. Then when dressing comes, when cases come back from theater, there's no, the way they go about the dressing, I said, no, this thing, it can't happen here. So I made the PON a coordinator for dressing. We found a place. So she has trained people who are now doing the dressing. So now we have a dressing room who is being managed, supervised by the PON. It's those that she has trained. And now I've made it that anybody who comes right from the student, they will pass through that place and no dressing, because it looks like people are forgetting the way we dress, the dressing. Because even students come and you ask them principles of dressing, they don't know. So this is the state of the wound now. It's another wound being dressed in a cheap compound. They are still dressing. They don't know what is happening. So it means our nurses and midwives don't even know how to identify a wound that is healing. So finally, sometimes some of the patients, they themselves will discharge themselves and move to the hospital. So they came and we are dressing. This poor young man, a graduate from one of our universities, just completed national service and was helping the mother in chopping kako, then traumatic amputation. He went to one of our lower facilities. In fact, they did whatever they wanted to do and took the money. The guy went home. No. So fortunately, he had a colleague, a relative who is a health worker. So he brought him to our facility. In fact, we couldn't stand it. When we went to the theater that day, almost all the fingers were almost off. The bones were showing, but this is a wound that has been sutured. Money has been collected. The hospital is just a stone throw. So we did it, and now the guy is fine. So if there's nobody there to intervene, what would have happened to this? A young, handsome man, graduate. This is how he has ended. This is a below-knee amputation. This person was discharged from a regional hospital to continue dressing. So the question is, in our hospitals, in our facilities, what happens in our dressing? What is the caliber of people we put in the dressing rooms? What happens? Because one of the facilities I went, it was one of the old health assistants who was in charge of the dressing room. So you can imagine what happens. And you want to change, then you become like something. So this man was discharged from a regional hospital to continue the dressing in our facility. And this is what we saw. And we continued, and that is the current state. I'm sure by now it has even improved better. Another wound, also, they went to the facilities, they couldn't help them, so they decided to go to a herbal home. That is how they ended up with us. So now, we as specialist nurses can also move to the communities. Yesterday, somebody was talking about sensitization at the lower levels or in the communities, screening and other things. I went to one of the facilities and I saw the kind of cases that were coming to the hospital. And sometimes they come and they tell you they went to receive treatment in a pharmacy shop and the outcome that they end up in the hospital, some of them were so bad. Sometimes when I'm reading reports, I even cry. I even cry. So I decided to start something, an outreach program that involved the whole hospital. So right from health information, we moved to the community. And I was the lead person because I didn't want anything to happen. So we had the midwives, we had the CHNs, and fortunately over there I had an ENT, I had a PON. So when we are going, we move as a team. Physician assistant, I had a dental physician, and then who is also doubles up as a physician assistant. So he becomes our prescriber. So we started moving to them in the community as specialist nurses with an ophthalmic nurse. So when we go, we manage all cases, pregnant women, those who have ophthalmic, ENT, dental. We even do extraction on site. And one day we went, and this is what we saw. This small girl was having this dental abscess and was at home. So we picked her up, brought her to the hospital, and managed her. So can we do something like that? So that we can be visible, because like they don't know what we have as CCNs. They only know the ICU, but people don't even know about the ICU. They don't know what happens at the ICU. Sometimes when I say I'm a critical care nurse, they'll be asking, so what is it about? You have to talk and talk, but still they don't seem to understand. So we have to make ourselves visible. Probably we might not enjoy the fruits now, but other generations would enjoy. You see? So please, let's not give up. Yesterday, when Auntie Fosti was presenting and some of the questions, I realized some of you were so sad. Let's not be sad. We are doing a lot, and we have a lot to do in the future. These are some ophthalmic conditions. They were all receiving treatment from the pharmacy shops and other things. And this is how they have ended up. In fact, if we had a third eye, we would have picked up this thing. Some of them will come to the health centers, a cheap compound, because they want the no-feel. They'll prescribe some ophthalmic eye drops for them. They'll go home. They think they are being managed, and this is how they will be ending. One of our outreaches, a small boy was having this plastic rubber in the nostril. The mother didn't know, so it was just a screening. Someone was mentioning screening yesterday. So occasionally in my facility, we organize outreach program. We go as a team. So one of the outreach, we saw this foreign body in the nostril of a 5-year-old boy. That's black rubber. I was wondering how long would this thing have been there, because the mother doesn't know that this thing was there. And we picked it up during the screening exercise. So we have so many opportunities to make ourselves visible. Have so many opportunities. And one day, in one of the facilities, we had a pregnant woman who was a regular attendant at the clinic. We were even expecting her to come and deliver. Then we were there. Then she came with a baby bed, not knowing she had delivered at home. In fact, I was very mad. Then I decided that I will go and see the TBA. So I followed up. And lo and behold, when I went to the TBA, these are the tools where the baby was delivered. So why won't we be having the neonatal deaths? So these are serious. You are fast. In fact, we have serious documentation issues. Sometimes my mess soup will call me and ask me, Didi, has the nursing changed? these are the people we are managing. Sometimes I don't even know what to do. But these are the people they have given you as nurses to manage. Hello? So if you have these people, you are managing them, what will you do? Can you set boundaries? You see? And now we have gradually, we have improved. So we have serious issues on the grounds. So at the top, we are doing very well. But what is happening down there is not helping us. You see, sometimes you'll be there and somebody will call you and the kind of words they'll be saying, nurses. And in fact, it's disgracing our noble profession. So CCS, let's rise up to the challenge and make ourselves visible through network of practice. This is one of the best ones. Probably if we want to do the research, when you come, we'll bring some out so that we see how all these things, some of these things can inform decision and policy. So, for discussion, critical care nurses must rise to the challenge of compromised patient safety by leveraging innovation, collaboration, and network of practice. Now, the song is network of practice, network of practice. What goes into it? Are they involving us? Do they know our importance? Do they know what we can do? In all the outreaches that I'm talking about, in fact, I confidently led a team because I know I can. And when we go on the field, I do everything, supervise everything. Even the final area, we go with medication. So I will be at the medication table and be serving, looking at the prescriptions that are coming, everything. You see, so that, and we have never recorded any challenge. These initiatives will demonstrate the potential of grassroots solutions to address systemic challenges. We have so many systemic challenges because in the above sense, there were interventions. A lot of interventions were put in place and they are yielding results. But sometimes you become overwhelmed. I'm alone. What can I do? What can I do? And probably when I leave, who is there to continue? There are other places that I started, I left, and now when you hear the story, it's sad. So how can we leverage the network of practice? So in the job description of the critical care nurse, I came across this. One of the main duty and responsibility is to supervise non-critical care nurses. So even we can do this, even in our own facilities, can we network, as we are saying? Sometimes outside the ICU in our facilities, what happens in the wards, very horrible. Even look at this amputation from a regional hospital. We may be having ICU critical care nurses there, but they might not know what goes on. So can we network and even descend? Another role in the job description is to undertake facilitative supervision. We can do that. Facilitative supportive supervision of immediate supervisees and facilities within our catchment area. Is there any policy supporting that? Can we leverage that? Come out with a policy that will empower us. Because for now, even with all that I'm saying, sometimes we don't have people, but fortunately enough, at any point in time, I have at least somebody, management members, who support me. But when you don't have these people supporting you, it wouldn't be easy for you because it's not part of the policy. So, can we have a policy so that this thing can even improve our conditions of service? We are able to do it well. It becomes visible. They understand what we are doing. We can even use it to negotiate our conditions of service. And this thing, I'm sure when you are going for supervision, will surely attract some form of allowances to cushion us. You see, assistance, so that the Barbados and whatever. Because our numbers are not too huge. You see, so they can do something. They can do something if we can convince them. So, conclusion, this visual presentation has highlighted some of the challenges at the grassroots that impact standard practice, standard nursing practice. The role of the critical care nurse in improving patient safety by rising up to the challenge through innovation, network of practice, to impact and inform policy changes, to support sustainable improvements in patient safety. So, in conclusion, sometimes, I won't do it again. I've talked, but you see, I came across this quote. Our lives begin to end the very day we become silent about things that matter. Our lives begin to end the very day we become silent about things that matter. So let's not stop talking. We'll continue talking. Even if they beat us, they lambast us, we'll continue talking and change things. CCS, let's rise up to the challenge. Thank you.
Thank you so much for having research endeavor. If you want to do an outreach, it will require logistics and then kind of some institutional support. Because so I want to find out, how does she get that kind of support? Are you doing it for free? Do you charge the people? Can I finish with, then you can address them, please? Then I also have a feeling that sometimes the institutions that even sponsor you to go and study, sometimes they don't have idea about the things that, or the capacity that you have built. And when you come back, they don't even sit you down to hear your side. Say, Amani, what about Amani? How was it? Is there something that you have observed that you feel that you can do something about it? It's just life as usual. And sometimes you can even be placed in a place that you are not so fit for purpose. And we have a situation where we are looking at academic qualifications. So you see that maybe the RN has done masters in psychology, RGN has done some masters in psychology, and that person is preferred over you because they feel that, oh, well, this is masters, you are just holding maybe a specialty. So you see that you go to a place that if it was a critical care that was there, or a PUN or a specialized nurse, you realize that things will be done better. Because the RGN, they don't know about some of the nitty-gritties of the things we are talking about. The wound dressing, the cotton wool. When you say it, because you are not in charge, they will say you some way. They will hear you out all right, but no, hearing you and maybe listening, putting what you have said into practice, maybe will make them feel of less, like they will not feel that important. So they will not take what you are saying. So how can management have a way of, rectifying some of these things? And then sometimes the protocols too are not there. Assuming, for example, the wound dressing we are talking about, do they have a protocol? Do they place the protocols? So now when they even have the protocols, they will hide it. They will hide it and then they will say, no, don't paste it. If you paste it, somebody will come and ask a question. If there is a visitor, they'll come and ask that, why is the protocol like this? They have to be questionable. So they are not so sure of the protocol, so they will hide it. It is only shown when it's peer review. And what I don't like about management is that when it's peer review, they will announce it on the page. The peer review team will become, we want to score high marks. So please put everything in order. I wish, please, the infection control prevention people, if you are coming, please don't tell us. Have a way of coming around unannounced and don't even wear uniform. Come ordinarily and take your photographs, evidence, video photo evidences, and then use that one as your recommendation or your marks. That will change the system. But this way of doing things like the inform management, we are coming today, and then everything is set. When they go, then we go back to our normal lives. What are we improving? What are we changing? Please, thank you very much. Last thing is digitalized. thermometer digitalization. The students don't want to learn anything manual. And most of the digital things, we all know they don't function well. And we are not up to the digitalization age we know in Africa. Yet, that is all they know. And we are getting wrong, results. Because the vital signs are all wrong. And they don't know how to check manually. So please, let's do something about that one too. Thank you.
We have ICUs that are unfortunately being headed by non-CCNs for the mere fact that they are PONs, okay, at our place. Yeah, POS is very, very critical. Like, I don't want to mention the exact place. So they should bring somebody higher with just one CCN, somebody higher. They brought in another person, a PNO, and that person was still a general nurse. And it's like confusion. They have sabotaged the critical care nurse. Unfortunately, she's the only person there, and they are doing their own thing. In such situations, how do we manage? What is there? CCN Krana no do this, and they are doing their own thing. How are we going to curb some of these situations? In fact, it's a problem. They will prefer the big names, PNOs, DDNSs, rather than listening to the CCNs. So please.
Hello. So I'll start from the outreach programs. It hasn't been easy, as you said, support. And the first facility I went, we started that one, there was no cost involved so much. But when I got there, OPD attendance was very low, and things were so bad that people would even prefer going to the health center than coming to the hospital. So, please are we together? What I did was that we organized sensitization programs, as somebody suggested yesterday. We moved from community to community. Sometimes I use my own money to support, to educate the people that they should come to the hospital. And that's what we're doing. We organized surgical outreaches in communities. So when they come and they see the changes, they go and inform other people to come. Sometimes management will not even give you anything. But at that time, I had a very strong team who were willing, zealous to support. So we did our own thing, and we had results. Yeah, the data is still there to prove the results. Then when I came to another facility, that was a health center, that one to the same thing. So what I did was, I started with my own money. Then I involved, my husband is a pastor of the Church of Pentecost. So I involved the church. So sometimes the church also help us. They support us in procuring some of the medications and other items. And I had the support of the district municipal director also, even though others were not supporting. But once I had his support, I was able to. Then in the third facility, what happened was that I wrote a memo to start. I was waiting for the memo for almost the end of the year. Nothing was forthcoming. So I started my own thing. So sometimes you have to be self-motivated to do your own thing. So I started, and it yielded results. So I did it afterwards. They gave the money. So that is how it continued. Then for the medication, we started collecting from the facility. At a point in time, they said the facility cannot continue. So I liaised with a wholesale pharmacy. So we go and we give it to them at the wholesale price. We don't sell. And then whilst we were doing that, there were other philanthropists. I remember we had a man who supported annually. So he would give us the money to buy the medication, sometimes to the tune of 10,000 cedis, to do everything for over 200 people. So people were supporting, churches and other individuals were also supporting. Then when you are trained, in fact, So the challenge you are saying, in fact, we also went through. I remember when I went back to my facility after CCN, in fact, we became a laughing stock. They didn't see what we were doing. But me, I wasn't moved because I knew what I was doing in the recovery ward. I knew the lives that I was saving, so I didn't bother about it. Then I decided to go to school. It was like, what are you going to do? I didn't bother. I went to the school. After the school, I decided to do MSc, advanced. When I came back to info, I said, what is that one to? I didn't mind. I did it. So sometimes you don't even have to listen to them. Be self-motivated. Then for policy, protocols and whatever, this is why we are doing some of these presentations. So our leadership should leverage on some of these things so that we can use it as a recommendation at the higher level so that we can become visible.
Thank you so much.